I was nodding off in between during the last couple of talks, so I didn't listen properly. You all have listened very well to all the talks on aspiration devices, aspiration catheters, and standard reverse. So you have to tell me how to do the case. Stroke can be, mechanical thrombectomy can be a very frustrating experience as well as a very, very gratifying experience, because most of the time, the stroke mechanical thrombectomy patient will come at the in the middle of the night, especially so if you are going for a conference. When you're on to the airport, you'll get a call from the hospital saying that the patient has come, and invariably that will be a well-informed patient who knows about mechanical thrombectomy. They'll tell that money is not at all a problem. They want the procedure done. And they have a relative in the United States of America who invariably will be a staff nurse. And that is going to screw up our life. So selecting more than anything else, it is a very, very difficult task. Now you don't have time. Yeah, you have to do the case somehow. So let's start with the case, and you tell me how to do the case. Carotid occlusion. Acute stroke with carotid occlusion, high NIH score. Patient has got a dense weakness. Opposite side injection, cross flow is not very good. A2 is good. There is bit of pile collaterals, but the whole area of MCA is occluded. There is not much of support from the posterior circulation. What to do? You tell me the devices, because I am the cath lab technician. You tell me, what to take and what to keep. Because you don't have time. Time is brain, no? You have to open the vessel. Sir, tell me, I am the cath lab technician, boy. Tell me, which one? Yeah, neuron max at suction aspiration at this place. So I'll give, suction aspiration, nothing happens. Yes, which wire? So I am the technician, sir. That is a problem, no? In the cath lab, you have to tell, you can't say that, like you can't tell that, like you take a catheter and open. Okay.
We have to take a combination of microcatheter, microwire, and suction aspiration catheter.
Okay. So you have different options. Now, either you can go with a micro wire, you can go with a microcatheter and a wire, or you can pass a small balloon, dilate it, or you do a aspiration as he suggested, aspiration of the thrombus and see whether it opens, or pass a small balloon and dilate it a little bit, and then over that, take the guiding catheter up, or as a last step, if it doesn't open, some people have tried it, reverse the thermo wire. You take the stiff part and then cross it. Sometimes it will dissect and open up, but that is the only way up if it is not crossing. So we did that. So here we are not very gentle with the clot, with the occlusion. You wriggle around, cross the lesion, take it up, it will go. You will have to struggle a little bit there. Then do a balloon angioplasty. What balloon? Any balloon illness, any coronary balloon. So this is what we see after that. So there is the ophthalmic. Beyond the ophthalmic, there is a clot. So this is a tandem occlusion. Now tell me what material to use. No. What? So React 71, took a React 71 up to the face of the clot, aspirated, vessel opened. Now what to do? But look at this partner, there is a large area which is still white. So one branch is occluded. You want to leave it like this or open it up? So what to do? Pardon? Yeah, which stent retriever? So it's an M2 occlusion. No? Catch mini or photon desoliter, which catheter? Which microcatheter? Any O2-1 catheter. So you take it, open it up, that opened reasonably well. There is some spasm in that branch, you can see that. That inferior division, there is some spasm there. But the vessels are good open. On the way back, this is how the carotid looks like. Kya karu? I mean, that is what we have learned. Anyway, the sheath is there. You relax, wait for some time. In the meantime, you can do if there is a expressity facility available, do an expressity and see how they, and wait for some time. The catheter, everything is there. So what happens is 50% of the time you do a check shoot, this will close. Don't think that now all these lesions remain like that. That is from, we have been getting tandem lesions left and right, and 50% you think that this is okay, but 50% of the time, half an hour later you do a check shoot, this is completely closed. Because you would have dissected the vessel, the endothelium is open and they go in for a closure. So that is the ideal thing to do. Rather than deciding on immediate stenting, 30 minutes later do a check shoot, and if the vessel closes off, only other option is to stent it. There is nothing else that can be done. So in the meantime, you do an expert CT and load the patient with antiplatelet medication. So that some antiplatelet would have formed. And if you have not loaded, give tirofiban a loading dose and stent the patient. And that's it. And the patient does reasonably okay. Tandem lesions don't do that well. Obviously, like the outcome is not that good as M1 occlusions. Ideally, yes. It is better not, because in 50% of the time the vessel will close off. But after that, if the vessel closes off, sometimes, suppose if it's a dissecting flap, you will find that it is very difficult to cross a lesion again. So don't take out the wire after that. Leave the wire always across it. Never take the wire out of the. So don't think that this will be stable, because most of the recent studies have shown that stenting in the acute stenting is the way to go. It is not that interval stenting. That concept is slowly changing. Now, there are three things that is required to do a successful mechanical thrombectomy. One is the skill set. Skill set means you should have hands, know how to handle the catheters, and you should have the knowledge of what to do, the anatomy, everything. Second is the tool set. You should have the hardware to decide, select the hardware, and you should have the mindset, which is that aggressive attitude to go at the middle of the night and to decide when to start, when to do, when to stop, all those things. That includes the mindset. So these are all three different talks altogether, but I'll just talk about the tool sets today. Now, what are the 5 things that you should consider when you decide on the hardware? Because every company is going to tell that my catheter is better, my hardware is better, my stent retriever is better. This has got. Now, I'll just share with you 10 tips and tricks on how to have a successful thrombectomy and what are the hardwares and things to use. The first and foremost is arterial access. So before that, I'll just talk a little bit about the standardized approach. Standardized protocol means this is a published data. It's not my idea. That means your cath lab has got a standardized protocol for mechanical thrombectomy. It is not case-based. The cath lab, the patient comes to the cath lab. The main problem is that cath lab technician should know what is going to be, that the doctor is going to ask for what material. Because suddenly you ask for React, suddenly you ask for another device, suddenly you ask for another stent retriever, then it becomes extremely difficult to arrange everything, and so everybody is confused. Because each player in the team has got a specific role to play. If you go to the cath lab, if everybody is running around, it is not going to work out. They should know that the cath lab technician has to do this job, other person has to do this job. It has to be designated to each person. Then only the cost can be reduced. You can have a big inventory if you stick to a standardized protocol, set of material you use in every time. Expertise also goes up because you use the same material again and again. You know how to take it up, how to take it into the beyond ophthalmic. Predictability also becomes 80 to 90%. If you have the same materials using again and again, 80 to 90% of the time, you're pretty sure that you will open the vessel. The case-based approach, what some people do this, first I'll try a simple stent retriever without anything. If it doesn't work, then I'll take aspiration catheter. If it doesn't work, then I'll take a balloon guide catheter. This is not going to work. Do a standardized approach each and every time. If you are comfortable with Solumbra, one particular aspiration catheter, one particular micro catheter, one particular stent retriever, do it every time. Don't keep on changing as and when you require. If you want to change, then change to another group and continue to use that for some time. So that should be the basic approach in selecting the hardware. The first step is, this is the most important step. the getting the arterial access. Why I am saying this again and again is because many times the patient is rushed from the ER to the cath lab table. Everybody is, you also want to do within 10 minutes because one of your friends, somebody has done 15 minutes mechanical thrombectomy. So he has put it in YouTube, Facebook, Instagram, everywhere. What to do here? I also have to do that. So what will you do? Immediately before the patient is kicking, moving, and you are trying to do a femoral puncture. And this is what happens. So you start kicking, the patient is moving, the wire is kinking, and take a shoot, all the contrast is out. And the patient had received TNK 2 hours before. And the game is over. You have to settle this first, then you have to go to the opposite side and puncture. It will take at least half an hour to settle all this. So the first thing is, the most important step in mechanical thrombectomy is getting a good femoral access. Because if you goof it up, the procedure is going to take at least 30 minutes extra. Your aim of doing within 15 minutes and Instagram fame is going to be a disaster. So this is what is going to happen. You take a check shoot and this is what is seen. What is it? Sorry. What is it? It's an AV fistula. So suddenly so always be very, very careful. So what you have to do is, take another 10 minutes or 5 minutes extra. If you are not able to do, are not confident, you are not getting the vessel properly, get the ultrasound. The ultrasound is so beautiful. You can see the line. Most of these newer ultrasounds have that marker on the probe. You know that. And then you just put it, you can see the vessel very well. You can very easily. This is one of the situations where you spend another 5 minutes extra to get a good femoral puncture. Don't goof it up. Use an ultrasound if required. So this is one of the essential steps. So once you get a good femoral access, then you go to the guide sheath. So guide sheath, the essential thing is the carotid in India, unlike the white population, comes in shapes like this. If there is anything more than 360 degree, that also will be there. So it is surprising, and invariably, a patient who is coming for mechanical thrombectomy, a VIP patient or an young patient, will have definitely a carotid which is like the third one. And that patient is known to one of your close friends who is a doctor. So these are the situations we face in our practice. Now I'll spend some time on this because this was discussed a little bit today. So this is the cerebase 80 centimeter. So when you take a diagnostic 100 centimeter and you take the guide cath, and if you are not exchanging in the aortic arch, it becomes difficult. You don't have much of the diagnostic catheter outside which is coming out. See that? If you take a 90 centimeter and if you use that longer Y connector, nothing will come out of the other end. So you should know this beforehand. You shouldn't try it and then find out that it is a mistake. So you take a 100 centimeter or a Bernstein 125 and use a smaller, you see that? You have a smaller Y connector attached to that, then you have enough length coming out of that, then it becomes easy. You have seen this, no? Most of the people use this. This is much, much more easier because the blood loss will be more. You just have to press Y connector. This is much, much more easier to use. Always use this because otherwise loosening it, tightening up, especially when you are aspirating or taking out, always use this Y connector. Now the third difficult thing is navigating the arch. Arch comes in different shapes like this. You have the bovine arch, type 3 arch, all those stuff. This is one catheter you should have in your lab. How many people have this catheter, this wire in your lab? How many have? Most of the people are used to, this is the, I'll show you this is the glide wire advantage. The tip is like a typical glide wire. It is so supple, but the rest is like the amplitude stiff wire. So this is one catheter the wire you should have in your lab, or if you want to do a left carotid, many times it is difficult. So you should have this. And this is the traditional ampullate stiff wire. The stiff wire is a stiff wire. You become so scared to use it. People, when you use an ampullate stiff wire, you're literally scared. But once you start using the ampullate, the glide wire advantage, it becomes so easy. I'll show you some examples. So this is an old man with a stiff arch, and the moment you start pushing it up, it starts kicking down. You can see that, no? It's coming down, coming down, coming down. This is an usual story. So left side, you know that this is going to be difficult. So always keep and you see once the glide wire advantage is put, it straightens up and it goes very easily. So remember, these are all very, very, because if you are not able to negotiate the arch properly and go into the left common carotid artery, what are we talking about? What is advantage of any catheter, microcatheter? This is going to work. And most of the people spend at least 30 to 40 minutes struggling in the arch, just trying to take the guiding catheter into the left carotid. Another situation. So what is this? The patient was struggling and the anesthetist gave quite a lot of sedative, and you can see that the catheter coming down. The patient, once they start snoring and breathing heavily, with each breath the catheter comes down so much that you can't push it up. It's not going. So when you change what do you do in such situation? You can put a nasal airway. We tried a nasal airway to reduce that snoring, because they snore so heavily that you can see that it's coming down. You can't push it up. And finally, there was no way we could take it up, and we decided to intubate the patient, and once intubated, it was going up very easily. So this is one situation when the anesthetist gives quite a lot of sedatives, the patient starts breathing so much that it comes to, see that? How much it comes down. So you should, when the patient is not breathing, you should try to push it up. When the patient is taking the deep breath, you shouldn't try. So we tried that, but it didn't work. Finally, that is the first step. When the patient is exhaling, you try to push it up. But that didn't work. Putting a nasal airway didn't work. Then finally, we had to intubate the patient. The patient, it settled down, and that was it. This is something which I read in the articles. You have a balloon guide catheter. You can inflate the balloon in the subclavian and try to go it up. Anybody has tried that? I don't think so. Okay. The other simple thing is to put multiple micro wires instead of, if the wire is not going up, and that is something you can try. I'm not a big fan of balloon guide catheter. How many in the audience uses balloon guide catheter? Not many. So I don't think, I'm not a big fan of balloon guide catheter. We'll come to aspiration catheters. The aspiration catheters, all the catheters available are pretty good. One of the problem we experience is all of them are extremely good. I wouldn't say that now. If you are consistent in using one catheter and use it every time, and as I said in the morning, foreplay is the most important thing. You give plenty of nimodipine before, so that the vessel is primed, any catheter will go up till the ophthalmic bend. Beyond that, I'll tell you how to take it beyond ophthalmic bend. Till the ophthalmic bend, if you prime the vessel properly, any catheter will go up. Now, this is one mistake which people make. So, for the guiding catheter, you can use the longer yellow one. But for the aspiration catheter, always use the small one. I'll show you why. Because you will struggle. I'll show you why you will struggle. And this is one mistake you shouldn't do. You want to see it again? You take an aspiration catheter, and without anything inside, you try to push it into the Y connector. The distal part will bend, it will get chinked. So this is one thing you shouldn't do. You should have a microcatheter inside, open it very well, never push it like this. I have seen it many times, some people trying to push it, it will bend and the catheter gets damaged. Now this is the most difficult part. Now you have crossed the aortic arch, you have crossed the carotid, which was occluded, and you go to the cavernous segment, which is the most difficult part. Now, this is the most difficult part to cross. How many have found it difficult? How many have found it difficult? People who have done good numbers of mechanical thrombectomy will say that crossing this ophthalmic bend, that shelf is the most difficult part in taking the aspiration catheter up. It is not the quality of the catheter. You can show that it will bend like this, it will go like this, nothing else, but it will not take this bend. So what will you do? So the first step is, don't struggle to take this up. Don't struggle. Your aim should be to take this stent retriever up, deploy it, then we will take this up. Understood? Now many people do that. Why I am trailing this again and again, many people try to do the aspiration alone. Snaking technique, you would have read it somewhere that somebody has done in 5 minutes. Just take the catheter, you just open, everything over. Not practical many times. It doesn't go. Indian population have this, the ophthalmic is always there like this form a step for the aspiration catheter. So you always take the microcatheter inside. I'll show you. So that is called the grappling hook technique, where you take the stent retriever distally, deploy it, and when you are unsheathing the stent retriever, slowly try to advance. It will straighten the vessel and it will easily jump and go up. 100% of the time it will go up. Because the stent retriever is hooking or grappling onto the M1. So that will straighten the vessel and that will avoid the ophthalmic bend. So this is why many times a simple aspiration doesn't work in M1 most of the time. Sometimes it works, sometimes it doesn't. But we want a technique where 100% of the time it works. So that's why we stick to that technique. Some people have tried putting a small aspiration catheter inside that. But the problem is, again, you are wasting time. You are wasting money. Why not put a microcatheter and stent retriever and do that so that you are opening the M1? That is the culprit now. Let the brain breathe. So you have another 5 minutes to wait now. You have deployed stent retriever. When you are waiting for that, you can always take the aspiration catheter into M1. Clear? So next time you try that, you take so for that, the main thing is, I'll come to that, one of the important steps I'll come to when I'm talking about the microcatheter. Aspiration pumps. There are different types of aspiration pumps used, but I think there is no significant difference between a hand aspiration and a aspiration pump. If you are comfortable, we were using it initially. If it makes life, because you need more people to have one at the guiding catheter, one on the aspiration catheter, 2 people to hold it, or you should have that lock thing. But aspiration pump is good if you can afford it. Cyclical aspiration is supposed to be better. That pump also has come, but not in India. Probably it helps. There are many studies now which shows that the simple aspiration is good enough. But maybe I feel that because of the tortuous anatomy of the Indian population, it's not that easy to take an aspiration alone without any support in the M1 in Indian population. Unlike there will be always so many loops, it doesn't go that easily. It will go till ophthalmic bend, but beyond that it doesn't go up that easily without any support. Now with the microcatheter, this is one thing you should spend some time on. So you should have, because you may not be able to take the aspiration catheter beyond the ophthalmic curve in most of the time. So you don't want to struggle there. If you don't want to struggle there, you should have enough length of the microcatheter outside the aspiration catheter so that you are not bothered. You are taking as a single unit the aspiration catheter, the microcatheter inside that, wire inside that. You will ask the technique, any wire will do. Most of the time you don't have to take a new wire. Any wire will cross the lesion. So take it as a single step and you don't bother about where it will go. So initial first part, don't take the guiding catheter all the way up. Keep it down, let the nimodipine flow, and when everything is in place, one by one, everything takes as a set single unit, and once the aspiration catheter reaches the ophthalmic curve, you wait there, I'll take the microcatheter up into M1, so that you are not stressed to take the aspiration catheter beyond the ophthalmic bend. Then take the microcatheter. So if you have enough length beyond the tip of the aspiration catheter, you can easily go into M1, beyond M1, deploy the stent retriever, unsheath the stent retriever. Then when you are unsheathing it, just pull the microcatheter a little bit and just push the aspiration catheter. It will just jump and go into M1. Always it will go. Now what is the next step? So this is the comparison of 2 catheters now. One is 150 and one is 160. This makes a huge difference. Because if you take a 150 or 155 catheter, it will not come out through the tip. It will come out, but only a little bit will come out of the aspiration catheter. So unless you take the tip of the aspiration catheter beyond the ophthalmic curve, you will not be able to cross M1. Clear? And phenom is O21 or O27 has got 170 centimeter. We use phenom all the time. So this is you can have the yellow one proximally for the guiding catheter, but the short one so that you don't lose much length here. On the aspiration catheter, you have the small Y connector. Clear? Cloud composition, stent retriever. There are so many stent retrievers in the market. Each has got its own benefit, advantages, disadvantages. But it is many a times now what you do is you deploy the stent retriever. What you do next is pray to God that and who can predict that? You think that it's a white clot, red clot, all, but it doesn't open. You think there is an ICS, there is an ICAT, it doesn't open. Sometimes it's open, sometimes it doesn't open. How many times we have found, 3 times you do it, you are 100% sure that it is an ICAT. But the 4th time it opens beautifully. So there is always a divine thing also there. So if you are comfortable with one stent retriever, use that stent retriever again and again. So that there are many advantages. Our lab has got at least 3 or 4 stent retrievers which are charged and kept ready. So that a poor patient comes we don't negotiate on have the financial counseling initially upfront. Because when you tell that, the problem with India, which most of the people don't understand, is when you talk about 5 lakhs, 6 lakhs upfront, unfortunately, they are also suddenly shocked. The patient comes to the hospital, and then you tell that you have to undergo a procedure which is 5 lakhs, 6 lakhs. Sir, are you sure about the outcome? No. Will he improve? I am not sure. Will he die? Maybe. Sir, what should I do? Then he starts calling up his friends. So they will say that there is a small nursing home nearby house. There was one stroke patient who went there. 3 months down the line, he started walking. Then he calls up the doctor who is a junior doctor, who is a partial MBBS, come allopathy, come Ayurveda. So he'll say that, you bring him over, I'll make sure that he becomes normal. Suddenly find that 3rd day later, he has come with a massive midline shift, and he has again referred back for decompression. That is the story that is happening here. So if you want to do a successful thrombectomy, the idea is not the hardware, it is the mindset. Mindset to help that particular patient. For that, you should have something in your kitty. Either you should have 10 lakhs fund, like from the hospital says that, you do that, we'll take care of that. Or you should have, you ask these companies, are buying and give one extra stent retriever free of cost. So you should have 2-3 stent retrievers free in your, we usually have 2 sets at least, which are charged and kept free in our lab, so that we don't even talk to the patient or bystander about the finance completely. It happened to me, I'll tell you the story. It's off the record, you don't record it. It was an extremely poor patient, a lady, 65-year-old lady with left M1 occlusion. So I didn't even talk to the bystander. I went ahead and opened the vessel. Within 15 minutes, everything was over. Then came out, the bystander's son, he said, sir, I don't have any money. Don't do anything, sir. We'll go to the government hospital. I had already opened the vessel. I kept quiet. I'm not doing anything. You go. It was charged just as a angiogram. And the patient was sent off. We can afford to do that because there is a lot of inventory in our department, and the hospital is also not strict about that. For that, you have to be consistent in using one material at a time. So you can ask that company, help me, give me a right of this particular product, so that they'll also help you out. 1 year, you stick to one company. Next year, you change your... it's not like a marriage, like right throughout your life, you have to stick to one person. Hope you understood what I'm trying to tell. These are all, embotrap is very good. All stent retrievers are very good. Now, if you ask any people, that is the most confusing. You come to a conference, Lomesh, what are you using? I said, I'm using embotrap, it's very good. So another person, he says that it's solitaire, it's extremely good. Catch view, it's extremely good. We have been using catch view, left and right. All these are good. Now, you consistently use it for 10 cases. You will find that you're very confident. You know that how it will function. You become expert. You can close your eyes and then push it. So that is the level of confidence because what is the main problem with mechanical thrombectomy is you are not doing it every day, no. Sometimes you do it once a week, then next 2 weeks nothing is there. So you don't become an expert now by doing a case. It's not like cardiology where they do 3-4 stents every day. We had this rapid medical thing for some time, but now it's not available. This is one thing now which everybody should learn, bare wire technique. So I'll again go back to that step in your mind. Just think your stent retriever is in place. You have just slowly unsheathing it. Once you have slowly unsheathing it, you have to push the aspiration catheter up. Why? Because the portion of the wire which is just attached to the stent retriever, that distal portion is not very strong. So you cannot advance the aspiration catheter over the bare wire. It has to be over the microcatheter. So the movement is like this. When you are pulling the microcatheter out, you have to push the aspiration catheter up. That should be a coordinated thing. You have to open the Y connector so that there is no resistance. So when you're pulling the microcatheter slowly out, you have to push so that opposite action usually slides the aspiration catheter up into M1. So once it is out, what you have to do, you have the stent retriever which is there. You can slowly, under fluoroscopy, see that the stent retriever is not moving. Slowly withdraw the microcatheter. So once it reaches the tip, so that there is no more wire left, what you should do? Don't try to just pull it out, because sometimes suddenly the stent retriever might move. So what is the technique that has to be done? I am the cath lab technician, you tell me. Take a 2 cc syringe, take some saline, and then flush. You just push some saline into the hub, and then as a single unit, so that there will be saline between the wire as well as the microcatheter, and it will come out easily. So that is the way, because the wire doesn't have enough length. That is another suggestion which we are making to the company. Why can't you make the wire a bit more longer? It won't cost much. So now we are we need microcatheters which are longer. We need wires which are longer. Wire means like the stent wire should be longer. So that now it is easier to, bare wire techniques makes a huge difference. Especially if you are using the double stent retriever technique, which Trilogen is an expert, you have to make it a bare wire technique. You use an 027 like catheter as a microcatheter, then the space available for aspiration is much less. So unless you have a bare wire technique, so this is one technique. Initially you will be scared now whether to take out the microcatheter blindly. So always use a syringe, keep flushing it, and then take it out, pull it out. Hope you understand. I don't have the video. Which one, how? There are so many techniques. Captive, arts, badass, protect, ASAP, stave, spap, save. Which is a technique you use consistently? People of... Now, in our experience, we use Solumbra maximum. We use 8F sheath. So it's a standard thing. They know that it's an 8F sheath. A guiding catheter is one brand, so use it all the time. Aspiration catheter is one brand, they use it all the time. Microcatheter is always 027, 170 catheters all the time. Stent retriever is all the same. So you don't have to ask. So you just have to start doing that. The cath lab technician will start giving one by one. You don't have to ask for anything. So that makes a huge difference. I'm not an expert in double stent retriever technique. We had a discussion. There are many types of double stent retriever. Some people put side by side. Some people put one into one branch, other into one branch. Maybe in I see a bifurcation, I see a top occlusion, or a stubborn clot which is not coming up from M1, going into M1 and M2, then probably you can try. Mevo, you can use the small stent retriever and see. But probably, I feel that in the future, maybe intra-arterial lytics or intra-arterial antiplatelet agents might be the treatment in Mevo. But with the newer aspiration catheters which can go into M2, along with the smaller stent retriever, might give an answer. Catch mini. This is usually tried in situations where when you do a thrombectomy and the clot has gone into A2 or clot has gone into M2, then as a complication, then we try to open the M2. But isolated M2s, no, people, if it's on the left MCA territory with a significant aphasia, one should try. This is one chart you should have in the lab. especially people who start working initially. This is another advantage of the chart is available from the net. You can get a printout and stick it in the lab. There are some apps also available where you can try out what are the devices compatible with each device. Because many times what happens is you don't look at what are the sheath he has given. You put up a 7F sheath, and then you try to push the guiding catheter. The fellow is not going. That thing is not going. So that is the problem when we have not given. If you give a set of things, a stroke thrombectomy set, this has to be kept ready. The cath lab technician knows that it is the 8F sheath that has to be given. 8F sheath is what color? Blue. But that mistake has happened to me. We were struggling to push the guiding catheter and it is not going. So because we are in a hurry to do the case, and nobody knew why this catheter is. We were trying to change the the guiding catheter. Then only it struck that we had given a put a 7F sheath. Small mistakes. Compatibility issues. This should be always kept in the lab. Closure devices. If you can afford, if you're an expert, you can use a closure device. It's good because the patient has already received thrombectomy. But many times we don't usually take out the sheath immediately. We can take it there, leave it there for some time. Maybe you can half an hour later, 1 hour later, you want to check again, do one thing. It's always better to leave the sheath there so that you can do again. But very rarely do we come across problems in the access, isn't it? Even though everybody is scared about patient has already received IVT, patient has received TNK or tirofiban, but very rarely do they have hematoma or any problem which significantly affects the management. And this is our protocol. You always put an 8F sheath, that is standard. A guide catheter which is 80 or 90 depending upon the length. If it is proximally tortuous, then we put 80. If it is straight carotid, put 90. Aspiration catheter 07 always, microcatheter 027, and stent retriever 640 or 440. This is standard. And then based on this, we might modify. Like if it's a tandem lesion, we modify accordingly. But always, the first attempt is always this. We stick to this. So the problem is we have a fellowship program. If they also start modifying and implementing and doing whatever they feel like, it is going to be a disaster, to put it mildly. So the problem with the mechanical thrombectomy, it's not you alone. So many people might be doing mechanical thrombectomy. So if there is a protocol, it becomes easy. Otherwise, it will go hayway. Thank you.
Thank you for the wonderful talk, sir. Any questions on hardware and acute stroke? Any?
These are all personal initial experiences. Initially, we started using balloon guide catheter. Once it did not deflate. So, it did not deflate. No? Then we had to ask everyone. Then people said, you have to poke it with another needle. And then so many issues. And the second thing, main problem is if you want to take the Solumbra along with a balloon guide catheter, you have to put a 9F. So you have to put a 9F sheath, then only a flow gate will go. Through that only you can take a 071 aspiration catheter. Probably it's a good idea, but if you are comfortable, you do 10 cases continuously and you are confident that balloon guide is the way to go, do that. But what I found is that unless you have with a tortuous anatomy like that, unless you have some support for the microcatheter to go, so you just put a proximal flow balloon guide catheter, and if you're planning to go with a microcatheter all the way to M1, sometimes it doesn't go. If the cavernous loop is a closed loop, it doesn't track that easily. Whereas you have an aspiration catheter in ophthalmic area, it gives good support, it will easily track. Balloon guide is good, definitely it is good. But then what happens is this is the problem which I've seen. Some people say that, okay, I'll use balloon guide. Then he tries with a balloon guide without an aspiration catheter. It doesn't work, then changes the whole system, then again goes back to the second set. So trying one and then going, the first attempt should be the best attempt. If you are comfortable with Solumbra, nothing about it. Do Solumbra all the time. It has been pretty good now, like almost 90% of the time we are sure that we will be able to open the vessel. First or second pass.
So I think balloon guide, if you were to do a carotid also, like there is a stenosis you need to do, balloon guide has a smaller diameter, I think. No, if you need to do a carotid stent concurrently with a stroke, balloon guide sometimes the diameter is
For taking a stent.
Yeah.
But no, you have the bigger 9F flow gauge is available now.
Oh, okay.
I have not tried.
Not always available. Where
Then there are many operators now who stick to balloon guide all the time. So they say it's good. But our anatomy is much more different. So you just go a microcatheter alone with a guiding catheter like the balloon guide in the proximal carotid will not give enough support. That's what we have.
Some questions.
Just for MEVO types of cases, do you have any feedback on the type of clot composition that you're seeing for specifically for MEVO? Is it more softer type of clot or like harder type of clots?
Most of the MEVOs which we see are what we create.
Sorry, come again?
What we create.
Just another
We
question.
usually send for clot analysis, but so far it has not been the reporting has not been, what's your?
We have had some MEVOs that we have seen, but I don't think the clot analytics have been very, consistent with the results. We have done a study on the types of clots that we have derived, and we do this always. I don't think there have been a correlation between the type of clot and the location. We have not got that. So like what Sir was saying, probably sometimes it's a distal migration of the clot, so it could still be RBC. Or sometimes it could be just a platelet-rich clot that is stuck there. So a MEVO and a clot correlation, I don't think any of our studies preliminarily has shown this.
Okay. It will be primarily a proximal clot which has gone into M2.
When you do the stent retriever or Salamra technique, do you pull the stent and the aspiration catheter together?
We pull it back halfway into the aspiration catheter so that the clot gets stuck. Initially we were keeping it completely outside and pulling it out.
Okay.
Then we found that it's better to pull it halfway through and then pull it out.
And then pull the whole system out. Okay.
Initially we were just keeping it completely outside and then it comes out like a railroad. Okay. Then we found that probably, when you pull it halfway through, half the clot goes inside the aspiration catheter. You can see the clot halfway inside that. So that gave us more confidence rather than leaving it outside.
And then do you do your run typically then through the...
As far as possible, we don't do any run. In the microcatheter, because the problem is one of my fellow, he did a microcatheter run and the patient bled.
No, like after you pull out the clot and whatnot, you want to just do a run to confirm that you cleared the...
Yeah, right.
So do you do it through the sheath then?
Yeah, we aspirate everything, let blood go, clean up everything.
And then just do it through the sheath. You don't go.
Sir was saying that he's not doing a
Microcatheter.
Yeah. Not through the microwave to confirm.
So that is only the senior people should do the microcatheter run. Why I'm telling is that this is a 24/7 365 program. You can't say that X person, the senior head of the department is not there, so today no thrombectomy. So you can't say that. So whoever is available should do the thrombectomy.
Thank you so much, sir. So your talk has been so clear that doctors have stopped asking questions and R&D have started asking. So, so that's how innovative it has been. Sir, thank you. Sir, I would like Dr. Gobindo Pramanik, sir, to kindly felicitate our guest, please, sir. A big round of applause to my mentor, please, sir.
I'm so happy that Kaushik, who was a fellow, he has grown to such stature and he is conducting his own fellowship program, and this is the first conference. A big round of applause to Kaushik for doing this.